Yes, on the full screen.
So I'm talking about a topic which most of us would rather not think about it, or if it happens, it's a horror person. It's a horror in reality. As I think I don't have to repeat what has already been said, the trigeminal neuralgia, and there is a neurovascular conflict between the fifth nerve and the vessel. And before going further, I'll just talk about two patients with whom I have had rather unfortunate experience. A 37-year-old female patient in 1994. She had right-sided trigeminal neuralgia of about 2 years duration. I did retrosigmoid cranectomy, opened the dura, coagulated and divided the Dandy's vein, and did a microvascular decompression. Immediate post-op recovery was uneventful. About 10 hours later, she complained of headache, vomited, and developed right-sided hemiparesis, and CT showed a cerebellar hemorrhage with swelling and brainstem compression. We did a posterior fossa decompression, inserted an external ventricular drainage, put her on ventilation, decongestants. Unfortunately, she expired after 3 days. She was my first patient for microvascular decompression. And in the words of, to borrow this line from Wilder Penfield, it is always better to do a thing wrong for the first time. But unfortunately, the problem got repeated in 2013 when in a 30-year-old male patient, who presented with the right-sided trigeminal neuralgia of 1 year duration, did a retrosigmoid cranectomy. Same sequence of events, we coagulated and divided the Randy's vein and did a microvascular decompression. 6 hours later, he complained of headache, vomited, and developed altered sensorium. And CT showed a cerebellar hemorrhage with swelling and brainstem compression. Posterior fossa decompression was carried out, EVD inserted, he was put on ventilation, but repeat CT showed a brainstem infarct, and he expired after 10 days. So this is a short video clip which shows the microvascular decompression. And here you can see the anatomy over here. That is the Dandy's vein, the trigeminal nerve, and as we go further in the dissection, unfortunately this video may not, okay, there you can see the neurovascular conflict occurring. And what the advantage of doing a section of the petrosal vein, that it gives an excellent approach to the anatomy. It defines, you can easily define the anatomy once the petrosal vein is away. But then that carries with it a lot of risks, what I'm going to talk about it now. And here you see this was the anatomy displayed after we sectioned the petrosal vein, and then this was the mobilized superior cerebral artery segment. And one can have even a venous compression, and this picture is not my own, it is taken from a book. And here you can have, this is showing the anatomy of the venous system in the region, and here you can see that there may be a compression because of the vein. And here, this is from my own record. You have a superior petrosal vein, which is pressing on the fifth nerve. And once you displace the petrosal, the vein, you can see a groove made in the fifth nerve. So venous neurovascular conflict can also result in the neuralgias. And so whether we sacrifice the petrosal vein aimed at getting a better view, having a better control of the anatomy, but at the same time risking the problem which I've just encountered. So here I came across this paper which was presented in CNS in 2017 by this gentleman from probably China, in which he mentioned that sacrificing the superior petrosal vein during macrovascular decompression does not increase vascular complication. Well, he said it is quite a harmless procedure. In MVD, there is no difference in the rate of vascular complications when SPV is sacrificed compared to those in which it is preserved. To better visualize a cranial nerve and optimize safe decompression, the surgeon should feel free to resect the SPV. Again, this is a very, one should take the statement very cautiously. Then the same authors published this paper in 2020 Operative Neurosurgery, March edition, in which they concluded that in MVDs, there is no difference in the rate of vascular complications when the SPV is sacrificed compared to that is preserved. And they reiterate that it is to best visualize the cranial nerve, optimize safe decompression. Surgeons should feel free to sacrifice the superior petrosal vein. But what does the literature of not so fortunate patients say? John, again in neurosurgery, few veins may be encountered in this surgical approach, which usually is not the case for trigeminal patient when this infratemporal approach is used. Sometimes it would be a disaster to sacrifice those petrosal veins ad libitum. Again, very important statement. It would be a disaster to sacrifice petrosal veins in each and every case. This paper appeared in ACTA in 2015. Venous sacrifice was made in 36.8%. And what do they find? That the study shows there could be changes in the evoked potentials when you're doing the venous compression. So venous compression or venous occlusion is not a harmless procedure. So there is another paper which recommended temporary clipping of the superior petrosal vein while recording the brainstem evoked responses. And they said that it is not a safe procedure. So you have to respect the SPV. This paper came in Neurology India in 2016, in which the patient had brainstem infarction, which was a complication of microvascular decompression or trigeminal neuralgia, in which there was avulsion of the Dandy's vein. A cerebellar swelling occurring after sacrifice of SPV during microvascular decompression for trigeminal neuralgia. Again, this has come in 2009, and neurosurgeon, as a conclusion, authors say neurosurgeon should pay close attention to the management of SPV to reduce the risk of venous complications. Sacrifice of SPV may lead to serious, potentially life-threatening complications. Another paper in which they said the authors reported cerebellar infarction following division of Dandy's vein in Journal of Neurological Surgery 2012. Then there was another paper in 2005 in Clinical Neurosurgery, in which the author reported postoperative cerebellar infarction in a 78-year-old after MVD who died because of pulmonary infection, and they recommended sparing of cerebellar veins. So almost author after author has recommended sparing of the cerebellar veins. So this is another observation in which the petrosal vein preservation has been emphasized. So I decided to see the textbook, Human's latest textbook published in 2017 edition. On page 1423, it says the petrosal vein is divided sharply after thorocoagulation. Their presence usually prevents full exploration of the nerve, and they can nearly always be taken with impunity. Same authors, same book, page 1425, after 2 pages. Cerebellar hemorrhagic infarction more often results from venous insufficiency, so it is important to minimize the number of veins sacrificed. They do a complete turnaround. So in conclusion, what we can what should be the plan for complication avoidance? The SPV complex should be treated with respect, and care must be taken to avoid its avulsion or sectioning. And MVD should be accomplished working around the veins. And this is extremely important, that we work around the veins and not try to save the SPV as far as possible. In neurosurgery in 2006, Origitano mentioned that I personally do not trust veins. Their variability in terms of anatomy and function, especially in the face of pathology, is a legend. It is my view that all veins are not created equal. Pathology, congenital variation, and iatrogenic intervention can alter the functional status of an individual vein or venous drainage. No one knows how many and which one can be taken without consequence. One finds out rather quickly when the threshold has been exceeded. I recommend the mantra of a vein is a terrible thing to lose. Preserve them all as often as possible. And coming straight from Leonard Mallis in 2001, the old neurosurgical principle that no structure should be taken unless absolutely necessary applies to vessels as seemingly well collateralized. We might think that the veins are very well collateralized. If you take out one vein, nothing happens. So it applies to vessels as seemingly well collateralized as the superior petrosal vein. So the moral is, or the message, what I want to say is, we must preserve the veins around the trigeminal nerve. Do not section them ad libitum. Of course, if there is a there may be some odd situation where you may have to section the vein. Otherwise, it should not be taken ad libitum. Must study the venous anatomy and try to work around the veins so that they can be preserved and you don't have the unusual or rare complications which have been mentioned. And if you just see this statement by someone, burn them and burn your fingers. That is Janetta. And I thank him and I thank the audience for a patient listening. Thank you very much.